everyone. This is Patty Post, your host of the Checkable Health podcast, and where we are bringing content for you to make healthier decisions for yourself and for your family. Today, my guest is Dr. Nicole Lovat. I'm going to give you a little bit of a disclaimer because I am under her care right now, and I am a huge fan of her. I've never had a practitioner that has been so keen to what I'm doing, and without ever meeting in person. By the way, we have never physically met in person, and I am so glad to be under her care. So, Dr. Lovat, thank you so much for joining me today.
Absolutely. I love talking about hormones. This will be fun.
Well, I love how you talk about hormones because I learn something every single time in how you practice virtually using telemedicine. It's just a great opportunity to actually have one-on-one time with a clinician, which is very rare these days, don't you think?
Yeah, absolutely. There's a lot of practitioners in this area that move on, and you have them for like 6 months to a year. They never get to know you, or you just have episodic care through the ER or urgent care. So it's nice when you can actually know your provider and they know you too.
Mm-hmm. So I'd love you to brag about yourself a little bit. Just tell us about your education and where you come from, all that good stuff.
So I was born and raised in Winnipeg, Canada. I did an undergrad degree in double focus in biochemistry and physics. So it was a double honors program. From there, I went into medical school, where I was recruited into the clinician scientist program, where you do your medical degree, your MD, at the same time as a PhD. And my PhD work was in pharmacology and therapeutics. So what that is, it's not like pharmacy where they tell you like how to dose things and drug interactions. It's focused on drug science. How do you invent drugs? How do you assess if a drug is good or not? How do you interpret clinical trials? How do you repurpose a drug? And also, how do you figure out whether a drug is safe? And so my focus was actually on insulin resistance, which is the root cause of obesity and diabetes, specifically in women, female rats. And I did a pregnancy study as well as a study just on non-pregnant females, using a couple of different therapeutics and preventatives to, prevent or reverse their insulin resistance. From there, I went into a residency program where I focused on rural family medicine. So I did a lot of obstetrics, emergency medicine, hospitalist work, and clinic. And I moved down to the US in 2018 to work at Mayo Clinic after meeting my husband, who's American. He kind of imported me. So I started my career off at Mayo. I've worked at various different health systems, both in the Midwest and on the West Coast. I've taught in different medical schools. And eventually I was lucky enough to stumble upon BHRT, or Bioidentical Hormone Replacement Therapy, because I was finding myself stuck against a wall with my patients. I could only get them so far with diet and exercise, and they still weren't fixed. And so this has allowed me to really fix people.
BHRT,
Bioidentical Hormone Replacement Therapy.
I've heard that you say the acronym before, and I've never put it together. Mm-hmm. So once you found that you went through a particular training, that's extensive training.
Yes.
And tell us about that.
So it takes about a year to complete. There's 4 parts. They last, it's about a 3-day course every time you take a part. And it's performed by Dr. Neil Rousier from WorldLink Medical. He's been doing this for a long time and is very experienced, knows the literature like the back of his hand. And it takes about a year to complete because you need that much time to read and study it and figure it out. I was very lucky. It was completely serendipitous. I bumped into a colleague at a filler conference, and we started talking about how mainstream medicine ignores diet and exercise and all these lifestyle factors, and they just put a pill on everything. Mm. And we talked about that. And then he said, you should go into this training. I think you'd really like it. And it was 2 weeks before we were opening the clinic, and I took the training. And I was like, okay, I'm not doing primary care anymore. I have to do hormones, because all of the women that I'd seen in my whole career, especially the women coming in with fatigue, cold intolerance, hair loss, inability to lose weight, period issues, infertility, I suddenly knew what was wrong with them and I knew how to fix it. So I'm like, this is what I have to do. And thank God I bumped into him and went to that conference, because it changed the course of my life and life of my patients.
It's very serendipitous, because once you learn that information, you can't just set it aside and be like, okay, I'm still going to do this over here.
Right.
You actually changed your business model, didn't you, with Firefly
Yes.
Medical?
Yeah. We initially were going to do like direct primary care, but after I took this training, I thought, this is actually how I can fix people. This is the missing piece. And so we decided to take a leap of faith and provide this service. And it's been wonderful. People have been very receptive to it, even though we're really the only clinic in the area that treats women. And, we've got a few Firefly babies, a couple already born and a few more on the way. And it's incredibly rewarding.
Oh my gosh, that just gave me chills. That is so cool.
Yeah.
Infertility is such a problem in this country right now. I think that it's cost prohibitive, and it takes just a lot of emotional energy as well. And for both the couple, the husband and wife have to go through a lot of emotional trauma there, or gymnastics. So going back to bioidentical hormones, what is that versus just a hormone replacement therapy?
Good question. So bioidentical is a term that describes the fact that these particular hormones that are bioidentical, they act in the body the same way as the hormone you normally would produce. So for example, your ovary produces estradiol, which is your estrogen in your cycle. The estradiol that I use, the body can't tell the difference between what would come from the ovary and what I'm giving you in a capsule. The reason that's so great is because then really your body knows exactly what to do with it. And there's a lot less side effects and risks with bioidentical versus, say, synthetic estrogen like Premarin or what's in birth control. They don't bind the receptor the same way. The body doesn't recognize them the same way. And so they have unintended side effects and different long-term consequences. The pharmaceutical industry was very interested in capitalizing on menopause because it's billions of dollars a year. And so they did a couple of big trials like WHI and HERS, where they studied tens of thousands of women using synthetic hormones. And unfortunately, when they didn't get the result that they wanted, they didn't turn around and say, okay, yes, we should use this stuff that's been around for a while, the estradiol and progesterone. They just said all hormones are dangerous and all women need to be off hormones. And unfortunately, that's, I think, part of the reason why we're seeing such high rates of cardiovascular disease and dementia in these women that were taken off these hormones.
Oh my goodness. Really long-term tragic side effects, consequences.
Yeah.
I didn't know that. See, I learned something every time that that we talk. That's awful. That's absolutely awful. And I feel like women have been abandoned by our healthcare for decades.
Yeah.
And I think in pharmaceuticals for sure. But here's another clear example.
Yeah. And I mean, one of the main reasons why is that they wanted to be able to patent synthetic estrogen and progesterone to sell them to you through your insurance, because they make a lot of money with that. But you can't patent estradiol because it's bioidentical. So there's really no profit in it because it's not a patentable drug. So no one can own it. Yeah.
So let's talk about the top 3 things that you're seeing in your patients. What would be the first thing that you're seeing the most of?
So in women, I would say my number one patient has PCOS.
Okay.
And those are women or young women like 12, 13, just getting their cycles all the way up into their 50s even, that come in with PCOS. PCOS is a spectrum. So you can be skinny or very, very overweight and still have it. It's actually a thyroid ovary issue. And it causes insulin resistance and an imbalance in your testosterone levels and hormone issues like not producing enough progesterone. So the excess testosterone produces extra hair growth, like on the chin, nipples, belly, or acne, like bad cystic acne on the face and back. And then the lack of progesterone causes a woman to feel like she's in menopause her whole life. So hot flashes, night sweats, anxiety, difficulty sleeping, issues with regulating your emotions, especially around your period where your progesterone levels are very low. And so you also get a lot of period issues like irregular periods, heavy periods. So then a lot of these women end up on birth control or they have fertility issues. So that's like probably my biggest younger woman entrance complaint. The second group would be perimenopausal women. And that window of perimenopause is say it's in no man's land. Like no one wants to touch it because they don't know what to do.
Mm-hmm.
So everything is normal. If you're bleeding like crazy, that's normal. If you're not bleeding, that's normal. If you feel crazy, that's normal. If you don't feel crazy, that's normal. So the real change in perimenopause that we see is as the ovaries start to fail, they stop regulating their estradiol production because you lose your hormone called inhibin, which basically calms your ovaries down and regulates how much estradiol they can produce. And then once you lose the estradiol control, then you get the bloating and the acne and you're feeling really crazy. And then you start to lose your progesterone, and the progesterone starts to give you, the lack of progesterone starts to give you night sweats and the mood issues and anxiety, and then and the heavy bleeding. And then if women can make it through menopause with all their reproductive organs, great. So it's usually OBs will give them a hysterectomy or an ablation for that. And then menopausal women would be my third group of women, where they might be even 10 years outside of menopause, and they have the weight gain from the menopause because they lost their hormones, and like the fatigue and the sleep issues. And then we try to get them restored back to like a healthy 25-year-old that doesn't cycle anymore. Like you have steady hormone levels the whole month.
From that, what are you giving them? Progesterone in menopause?
Yeah. So pre and perimenopause. So when you're cycling and when you're in perimenopause, we give progesterone, and then we can consider thyroid and testosterone depending on your symptoms. But then once you're in menopause, you need your estradiol replaced as well, because estradiol has all of these wonderful effects. And if you take it by mouth, so not a pellet or a cream, your liver breaks it into a metabolite that actually chews and remodels up all your plaque in your body and helps maintain your brain health, so reducing your Alzheimer's risk. It helps push sugar into muscle, so it keeps your blood sugars controlled and helps you lose belly fat. And it does have an effect on craving. So if you get the estradiol levels corrected, then women in menopause will feel like they are less snacky, they're craving less sugar, more control over their appetite. And it's also a very powerful antidepressant for women. So when you have like a nice sweet spot of a level, women will feel like their mood's really good.
Yeah. I mean, personally, from like Patty in January versus Patty in June, it's like the emotional roller coaster has stopped being like super up and down. It's just pretty even keel. The best sleeps. And my symptoms were also my hair was falling out and really heavy bleeding, which was like making me not functional for a couple of days of the month. And you're absolutely right. Every OB was like, oh, well, that's normal. Or you should have an ablation. I'm like, that doesn't seem, or you should get on birth control when I have my tubes tied. So why would I don't need that. Why would I need to take that bill? It is something that is expensive from the side of it's not covered by your insurance.
Right.
And that just feels like it just is like a no-go. Like, oh, I'm not going to do it then if it's not covered my insurance. And what my response to that is, well, don't you want to invest in yourself to feel better?
Right.
But what do you think that societally have we accepted not feeling good or accepted like this way of life?
I think to some degree, yes. I think that we are used to sick care. So you get care when you're sick, and then when you're healthy, you don't need care. Whereas my model is, if I make you really healthy and happy, then you don't really need me.
Yeah.
And that's kind of my model, is like wellness care.
Yes.
But when patients are paying, when they're employed, they pay their insurance premiums, they have a deductible, and they start to have this mindset of like, well, I'm going to just keep going to my primary, who's not getting me anywhere, and can't actually, their hands are tied because they can't use these medicines. But I'm going to get my deductible and my insurance will pay for it, versus, okay, I used to spend $7,000 towards my deductible a year. Well, now I'm spending $4,000, but I don't need to go to my doctor anymore, and I'm not on any medications except for hormones and vitamins. then you're actually saving money. And long term, when you look, especially when you're in your 40s, a lot of the problems you're going to get in your 70s and 80s are starting in your 30s and 40s. Like
Oh,
we know
really?
we can look back and say, okay, if we looked at your blood work at 35, we could tell you we're going to get dementia at 68.
Oh, wow.
So if you can reduce your risk factors when you're younger and you're still working, when you get to be older and you need to go into a nursing home, for example, or assisted living, they take all of your money. They charge you like $10,000 or $15,000 a month to look after you. They're going to get you coming or going. And so if you invest in your health, you actually will probably be somebody who maybe doesn't need to go to a nursing home at that age, or maybe can just get by with assisted living in their 80s before they need more help. And they have a better quality of life. Like they feel like they want to hang out with their grandkids. They want to go for a walk. They want to cook. They don't just want to sit in front of the TV.
Oh, I love that. Yeah. I want to live till I'm 112. So this is great.
I'm shooting. Go ahead. Sorry.
What are you shooting for?
133.
133. Yeah. We talked about this actually in one of our one of our meetings. And I remember thinking, gosh, she's really an overachiever than I am. So you have done this yourself. You have treated yourself. So can you tell us about that? I think that's a really big thing that people like, oh, no, I practice what I preach.
Yes. So at my heaviest, I was put on birth control when I was in my late teens because of really awful periods, which turned out to be endometriosis. Okay. And they were so bad that even though I was, working multiple jobs and in high intensity school, I would miss like a day or two a month, and I would be puking. I'd be on the floor in the fetal position, not normal. So I was put on birth control. And unfortunately, when you have PCOS, you can get really bad weight gain on that. So I gained about 100 pounds. So at my heaviest, I was about 270 pounds.
Oh my goodness.
And so I was an obese diabetes researcher in medical school, being like, what is going on? Like, I'm eating a high carb diet. I'm going low fat. I'm eating like 1,000 calories a day. Why can't I be thin? Yeah. And well, as it turns out, I needed my thyroid optimized, but I did lose about half that weight just with low carb diet, intermittent fasting, carnivore, that kind of stuff. But then when I went to this training, I also knew what was wrong with me, because before thyroid, if I ate a piece of fruit or a carb, I would gain 5 pounds. I had to be really, really strict with my diet. And I was fatigued, and I was so cold that in the afternoon, when my T3 levels were the lowest, I would actually have to go and take a hot bath to get warm, because I'd be like, my teeth would be chittering. So cold. And then also still having the endometriosis problems, like the pain and the heavy cycles. So once my thyroid and my progesterone was optimized, I mean, I don't have any issues. I'm able to sustain a pretty high workload, and I'm warm. I'm using air conditioning again in the summer, which is nice.
You're like, I loved it when you said that you have superhuman, you feel like a superhuman because you're working the ED, you're working clinic, and then you're working Firefly as well. You're running your own practice.
Yeah, well, the clinic would be all Firefly, but the hormones and the aesthetics. And then I have a full-time ER job as well.
And how many days in a row you're there consistently?
My stretch is a 36-hour shift on, and then 36 hours off, and then 48 hours on.
Okay.
So it's like a gauntlet every 2 weeks.
And that just super random, but do they let you sleep? Like, are you sleeping in a...
Sometimes we won't get sleep if patients come all night, but usually you get 2 to 6 hours of sleep. Okay. But it just depends. I've had shifts where it's been bedlam the whole time, and others where I got to have naps.
Yeah. But that's not consistent. That's like not a good night's rest where you're just letting your body wake up in the morning. It's like jarring and
exactly. But
you still are great. Like, you still always have a reasonable amount of energy.
Yes.
If not more. Yeah. So one thing that is controversial is the testosterone cream. And it's just seems really interesting to me because there's so many companies that will prescribe for men and ED, or I I don't know, what other things are they getting online prescriptions for without even a visit?
Like
But then,
clomiphene or Arimidex and other things like that. Yeah.
yes. And those are all for sexual performance, I would assume. But when it comes to women, that we have, it's considered a controlled substance, and OBs say that there's not enough data out there to make any claims that it does anything for a woman's sexual appetite, let's call it.
Well, so testosterone. So this is why the reason why providers think testosterone is dangerous in women is it's because they're interpreting a study that's observational, and they're saying it's a cause-effect relationship. So when you look at women with naturally high testosterone levels, they have higher rates of breast cancer, uterine cancer, and ovarian cancer.
Okay.
And that's because they have PCOS. That's why they have high testosterone. And it's like, not because we gave them testosterone, we didn't give it to them. It's not an interventional trial, it's an observational trial. So it's associated with. And as soon as that happened, okay, testosterone, we don't want to give women testosterone because if they have high to start with, it's dangerous. But the real reason that women with PCOS get breast cancer and these other female cancers is because they don't have progesterone. And progesterone is what's counteracting that estrogen in all those tissues. So it's not the testosterone's not doing anything. It's actually the lack of progesterone that's causing that. It's like if you looked at smokers and saw their fingers covered in yellow, you would say yellow fingers causes lung cancer. Well, it's smoking that caused it. And chopping their fingers off will actually help reduce their smoking, but it's not gonna actually be a real effect. It's because you change their behavior.
Yes.
So that's the big thing with when primary care is like, you can't be on testosterone. You have a family history of breast cancer, or you're going to get breast cancer from that. It's actually because of that observational data. In fact, there are studies out there that show actually high doses of testosterone are apoptotic to breast cancer. Apoptotic means testosterone binds the breast cancer and the breast cancer kills itself because it can't handle the high level. And in terms of why they say that it doesn't help sexual function is because they're not using the right dose. So for example, Androgel is the commercially available male testosterone cream. It's 1%. I start women on 2%. So they're not using enough. And if you use commercial gel for men, they would be worse too.
Oh, that's super interesting. Yeah. Cause even when you kick it up to 3%, you can tell.
Yeah.
Oh my gosh. It's like what happened. It's like a light switch.
It is like a light switch.
It's crazy. So it also makes, just think of marriage relations and how important that is to your spouse.
Yeah.
That it's nice to like be on the same page then and not being like, I don't care about that. Right.
It's like
you don't
a chore.
Yes. Yeah.
Yeah.
Yeah. It's very, I didn't think that would be a side effect, and it is. It's a great side effect.
Yeah, that's another reason why I use cream over pellets is because when I put a pellet in, I have no control after I put it in. So for 3 to 6 months, it is what it is. Whereas with the cream, we can kind of slowly increase the dose to get you to that light switch moment, like, oh, I want sex.
Yeah.
And I'm interested in it.
Yeah.
And then we keep you there instead of kind of going up and down as the pellet wears on and wears off. But I've heard that from many of my patients, like, you gave me my wife back, you gave me my husband back, because that libido, I mean, if you think about when people get their divorces, it's like in their 40s and or when they're going through menopause and they're like, oh, I can't stand this guy. He's so annoying.
Yeah. And then you just trade him in for someone else that's probably annoying. Like,
right, exactly.
It doesn't do anything. Like you ruined your family, and not ruined, but it's
changed.
It changed. It's a change. So one thing that when we were talking early on, I mentioned something about like what insurance will cover on what was it? Rectus abdominis diastasis, and how women that have given birth, all of us have that. I mean, or have been pregnant, and to sew them back together, it's not covered by insurance because it's a tummy tuck is basically what they call it. And I was upset by that. I'm like, that just, because it hurts your back, right? Like if you have rectus diastasis, you have a sore lower back the majority of the time. You can't do anything about it. And you mentioned something about a woman that had a sore neck. Will you tell me about that story?
Sure. So there's some muscles in our body that seem to be more sensitive to certain hormones. And what I've observed is there's this chronic neck pain that women with low progesterone get, where they get tight, like over the traps and in the muscles and their shoulders, kind of their shoulders feel like they're up by their ears. And progesterone binds the GABA receptor, which is the same receptor that alcohol binds, and causes relaxation. And a lot of my women with chronic neck pain due to neck tightness with low progesterone, they get marked improvement in their neck pain. So I personally was getting adjusted at twice a week. I had a range of motion that was like about this. And then within a couple of weeks on progesterone, full range of motion. When I used to put my head forward, it felt like my head was just going to fall off. And now I have like normal strength in my neck. Life-changing.
Wow.
Yeah.
That's so interesting.
But a lot of the women, older women with PCOS, you'll see in their medical history, they'll have had neck fusions because they keep complaining of neck pain. And so they fuse their neck because they get degenerative changes because of their necks not functioning. And then they'll get a fusion and they needed progesterone. And the same thing with the tummy tuck. Okay, don't fix my separated abs. Now I'm going to get chronic low back pain, and then you're going to do back surgery, which will be covered.
Right. That's what a fusion is covered. That's what's so frustrating. It's like you'd cover this back surgery, but then you won't cover, and you won't cover the progesterone either, or you won't cover the stomach surgery. I mean, that's so frustrating with our healthcare system that it's all what is under coverage.
Right.
And who ends up making the money?
Right.
The insurance companies. And they decide what gets to be covered because they own the companies that also make those decisions.
Right.
Yeah. So it's not just women that need to look at their hormones, it's men too. Can you shed some light on that?
Yeah, absolutely. So a lot of my male patients come to me because their wives, their sisters, their mothers are getting treatment, and they realize, oh, you know what? My son is overweight, depressed, anxious, and tired all the time. He probably needs his hormones checked. So that's how most of my patients come to me. Men, I think, compartmentalize better, or they accept, like, you know what? I'm in my 60s. I should have achy joints and have a gut. Like that's just life. Whereas, women might realize, like, actually, I don't want to have a big belly and be tired all the time. Like I'm not accepting that.
Right.
And I see men in a couple different life stages. I see men that are in andropause. Andropause is male menopause. So at some point, their testicles don't make the hormones for them anymore. And then they go through a lot of the same changes as women do. So they get crabby, they put on weight, they lose muscle. And to fix that, you replace testosterone and sometimes thyroid hormone, depending on how much insulin resistance they have and how many thyroid symptoms they have. Another group of men is in kind of like periandropause. So just like perimenopause,
Yeah.
you're in your late 30s, in your 40s, you're done having kids, you're kind of starting to slow down, feel a little tired. You're not as severely low as maybe someone in andropause, but you still would benefit from being optimized. And then we will, have the talk about when you're on testosterone, that means you're done having your kids because it kills your sperm count. They accept that. If they're done their families, we can fix them using testosterone. And then I have younger male patients in their teens and 20s. Usually they came from like a pregnancy that had a lot of complications like obesity or thyroid issues, and they have kind of lower hormone levels. So what we'll do is we'll try to optimize their thyroid to get control of their symptoms from thyroid and hope that their testicles will make them more hormone, or use things like HCG, which will stimulate the male testicle before 40 to help produce more testosterone.
Oh, wow. And are all these pill forms, capsule forms?
The testosterone for men is a cream.
Okay.
It's 10 to 20% concentration. And then thyroid is pills. And then the HCG is an injection. It stands for human chorionic gonadotropin, and it's the pregnancy hormone.
Oh, yeah. Okay.
And the way it works is it looks a lot like luteinizing hormone, or LH, which stimulates the testicle to make more testosterone.
Oh my gosh. It's just like a one thing. It's all leading to one another.
Yeah.
Huh. That's real. I didn't know that there was like state phases of life for men when it came to hormones. I thought it was like 80, they just stopped making sperm or something.
Well,
Like,
what's funny is that the fact that you mentioned 80-year-old men, the normal range for testosterone in men is based on a Medicare database study that would make old men, 95% of them normal. So
oh,
the normal range on the lab actually is not like, I wouldn't want, if I was 25, I want to be normal for an 80-year-old dude. Like
right.
that doesn't make
Yeah.
sense. It's so that that people don't qualify as hypogonadal or like low T, so they aren't entitled to treatment.
Now, when you look at all the blood levels, is that how the normal is always at 80?
Well, it depends. Sometimes normal ranges are based on a small group of sick people, or they're based on a database study of old people, or we think this is about what the average person is in this range. They're not like what you would strive to be. They're not like this is what you would want to be. It's like what is typical, or what have we studied, or what have we noticed.
So it's like so mediocre. It's like, okay, you're within, I don't want to be of the range of a sick person.
Exactly.
Or of an old person, or of a
Correct.
mediocre person. I want to be like, okay, what are the professional athletes at?
Yeah.
Or the other CEOs, the highest performing providers. That's what I want to be at, that are in their optimal health.
And male testosterone is down about 50% from what it was 50 years ago.
And why is that?
Probably multifactorial. Like we have a lot of pharmaceuticals in our drinking water, that including birth control, that affect men.
Okay.
The soy, which is estrogenic, the processed food, the lack of sunlight, the lack of exercise. There's some studies coming out now that show that our mitochondrial metabolic rate is dropping. So we actually are burning less fuel as a society. So we actually, our metabolisms are slower than they were in the past. So I don't know what's causing it, but I can say that a guy in his 30s now has like the testosterone of a guy in his 60s from the 1980s.
Oh my gosh.
Like much, much lower.
That's so bad. That's so bad. That's like, for our next generations, that's going to make a difference.
And I think it explains partly the mental health crisis in younger people, because in men, you'd think testosterone would make men aggressive, but it's the opposite. It's like a mood stabilizer. Like they get less anxiety, they sleep better, they don't sweat at night, they just feel calmer, versus gym steroids, which are like birth control, they're synthetic.
Right.
That, hit the testosterone receptor like 1,000 times harder than the testosterone would.
Yeah.
And those can have some like roid rage issues, but real bioidentical testosterone just makes men feel calm and happy and energetic.
Wow. That's very interesting. One thing that with the supplements that you had recommended that I thought was interesting was iron. So I've always had a very low iron. I don't know if I'm anemic, maybe, but you suggested don't use the vegan iron that I was using. My body's not. What happens with the vegan iron? Why don't we? That's normally what you find.
There's a huge push for plant-based diets right now, which is again multifactorial. But you can stop me right there that it's sponsored by Coca-Cola and Pepsi and Big Food. So because you can make processed food that's plant-based, but you can't really make plant-based meat very well.
Right.
So can you repeat your question for me?
Oh, just curious about the
plant-based iron.
Yeah, the vegan iron. Yeah, plant-based iron.
There's two different types of heme iron. So animal heme and plant heme. We're animals, we're not plants. So when we intake animal heme, it's a different structure, and our bodies can absorb it and then turn it into like things that are made of iron, like red blood cells. So when you're taking a vegan iron supplement, you're probably not really absorbing very much. And if you are, it's not very bioavailable or useful for your body.
Oh.
So I either use like a chelated iron if people can't tolerate beef liver, but I love beef liver. I think it's great.
Do you just make it, beef liver?
I don't eat beef liver. I'll eat chicken liver, but what I just do is I get just dried capsules of beef liver.
Yeah.
And then you don't have to chew the liver.
I had a pill on here. I was going to show everyone, and here, I put it away. So it is, I just got Got it on Amazon. There's a couple of good companies now that I actually really like their content and what they're putting out there in terms of like recipes. They'll do I saw one the other day. It was like mangoes with 3 raw eggs and yogurt for a smoothie. And they were talking about the raw eggs, how that's actually not bad for us, and raw milk. Do you drink raw milk?
I do.
Do you?
Yeah. And my husband is, he'll have a dozen eggs a day in shake form.
Willie, okay.
Raw eggs, yeah.
Yeah, he'll just put it in the blender. And then what does he put with it? Does he just drink it like that?
He puts in a little bit of, because he's a little bit lactose, so he uses some goat whey protein, and then a little bit of blueberry, like just a tiny bit of fruit to make it taste good.
Yeah.
And if he needs it sweetened, he'll put a little bit of honey in.
Yeah.
And some lactose-free milk, or he'll use macadamia milk or something like that.
A dozen eggs a day. Oh my goodness, he is getting a lot of nutrients.
Yeah.
I have 2 poached eggs every morning with my 9-grain toast, though. Now, one thing to end, I want to talk about postpartum. So one thing at Checkable, we are doing the breast milk strips for nutritional value and then to measure alcohol. And in that time of life, postpartum, I vividly remember with my 2 boys, it being very much of a roller coaster for me. But then with my daughter, my OB had me start Zoloft the day that I delivered. And that was a much better experience for me. But I wanted to get off it quick because I don't like to be on a pharmaceutical drug. And so I got off of it about 6 months and it ended up being fine. If someone else has that same frame of mind of like, okay, I just don't want to go on an antidepressant, can you tell what's happening in our bodies and then what's something you can do to combat postpartum depression?
So postpartum depression, I would say in the majority of cases, is actually a progesterone withdrawal syndrome. So while you're pregnant, usually starting in the 2nd and 3rd trimesters, your ovaries are no longer the majority producer of your progesterone. Your placenta makes it for you. Your placenta values in pregnancy can be very high, like 20, 30, 40 times what you are when you're not pregnant.
Wow.
And then that progesterone is an anti-anxiety hormone. It relaxes your muscles. It lets you sleep. I don't think women could tolerate being pregnant without it. It's because there's so much estrogen, right? And so when you deliver your placenta, your progesterone plummets. And if you have the predisposition towards that inflammatory response in your brain and then withdrawal, and your ovaries don't reboot really quickly, usually this is more women with PCOS, you will get progesterone withdrawal. So you'll be sweating, you'll be irritable, cry at the drop of a hat, depressed, anxious. The drug companies know this is progesterone because their new FDA approved intravenous treatment for postpartum is a downstream metabolite of progesterone that they modified, that they give IV. So my treatment for it is to just wean you down slowly off your placenta. So let's say you deliver and you need 1,800 milligrams of progesterone. We slowly drop it. I actually give my postpartum ladies an injectable form in case they're feeling suicidal or really dark. They can inject and that usually resolves their symptoms. And then we just slowly taper them down to a level where when their ovaries start working again and their body resets, they can go back to their pre-pregnancy dose. But it's really sad to see. Dr. Rouzet's told stories in the training of, he's an ER doctor as well, and of a lady he had that was suicidal, postpartum depression, and he gave her a shot of progesterone, and an hour later, she's like, I feel like myself. What did you give me?
Oh my gosh.
The idea that we give women antidepressants just drives me crazy because I haven't encountered a patient that didn't respond to progesterone.
And progesterone can also be used for infertility then as well.
So if you have, it's called a luteal phase defect. So if you're not making the right amount of progesterone after you've ovulated and have your embryo, or sorry, I should say the fertilized egg ready to implant, you can start progesterone, and then that gives it the ability to actually implant, and it can stop you from miscarrying.
Wow. So that is a lot of your Firefly babies.
Yeah.
You were with them. They were trying to conceive and they kept miscarrying.
Yes. or a few of them from the, I mean, it must have been just complete luck or serendipity. They had their consult the day or within a few days of finding out they were pregnant. So I could immediately draw their labs, give them some progesterone, and they're all pregnant right now.
Oh, that's so awesome.
Yeah.
I love that. What a wonderful story and journey that you have been on in your practice and as a provider to continue to learn. That's where I think a gap in, I think all doctors are they must be naturally curious, but the health systems are burdening them with so much that your energy level to continue to learn and your ambition probably fizzles out. And so it's always a pleasure to talk to you because just like you said, you referenced the study that you just read. I really appreciate that you're just always at the top of your game and bringing the best care to your patients.
Thanks, Patty. I appreciate the opportunity to talk about hormones.
Yeah. So you have, tell us about what states you're licensed in now, because some of our listeners are around the country. And if they want to access you, they could go to fireflymedical.net, but they need to be in the right state.
So option one would be for them to come down and see me in North Dakota to establish care, and then they can go back to their home state. I'm licensed in North Dakota, Minnesota, Idaho, Washington, Montana, Utah, Virginia, and I'm working on my Florida, Texas, and Massachusetts licenses.
Wow.
And I'm also licensed in South Dakota as well.
Okay. Yeah. Holy cow. That's so great. And so just of establishing care, so we need a hands-on visit first.
Yes. So the FDA and the DEA changed some rules May 12th of this year. There was some relaxation of some rules to accommodate for COVID-19 restrictions. So now for any prescription of a controlled substance, whether you're male or female on testosterone, you need to have at least one in-person visit to establish care. And then everything else can be telemedicine, but and you cannot prescribe more than a 30-day supply of that controlled substance, i.e. testosterone, before you have that encounter. So you just have to time it properly.
Got it. Okay. And the majority of your patients are in North Dakota, though?
Yeah, North Dakota and Minnesota. And I'd say 75% of my female patients are kind of scared of testosterone to start with. And so they usually wait to start it. So that gives us more time for us to meet in person.
Oh, interesting. I wasn't scared.
Yeah, you're like, let's go.
Yeah, I'm like, let's just get into it. Which is funny because I don't like prescription drugs, but I bought into everything that you're saying, and I really feel so healthy and have lost 15 pounds and have so much energy to do everything that I need to do. So I'm happy with it.
That's great.
Yeah. Well, Dr. Lovat, thank you so much for joining us today on the Checkable Health podcast. It's very much of a pleasure to talk with you. And if anyone wants to follow Dr. Lovat, Firefly Medical is on Instagram as well as Facebook. And then we'll put some of her things on this overview.
Sounds good.
Thank you for joining me, Nikki.
No problem. Thanks, Patty. Have a great day.